Dr. Karthik.
Into mark.
Dr. Karthik.
Yes, sir. Good evening, sir.
Switch on your video, Karthik.
Good evening, sir.
Good evening, Karthik. Karthik, you'll be presenting first, and initial half an hour will be for the examination and the history part of it. Later, we move on to the management part of it. So, if you have a problem,
Okay,
you
sir.
cannot answer, please tell so. The faculty will try and help you. Can you try share?
Okay. Yes, sir.
Esteemed faculty, dear students, apologies for the few minutes delay and the challenges in joining. Today we have two important exam cases, a case of CA tongue and a case of multiple adenopathy. CA tongue is kindly presented by Dr. Karthik from Government Hilpak Medical College, Chennai, with Professor M. Parimala Madam is the faculty in charge and the head of the department. Abhilash is from Government Medical College, Calicut, Kozhikode, kindly contributed by HOD, Professor MP Sri Jayan sir. And we have three eminent faculty and many in-house faculty. Dr. Medha Sugara is just completing her surgery and she'll be joining soon. Professor Mohammad Ibrahim sir and Professor Prabhakaran sir are from ESA Medical College and Chettinad Medical College. And I also warmly welcome our own senior faculty here who have been with us all through. I could see Professor Khanna sir. I think Medha ma'am is joined already. Professor Ratna ma'am, Ratna Chopra ma'am is here with us. And Raji Sakai sir and others. Warm welcome to all of you. I request, except faculty, all others be on mute mode, please. So, Dr. Karthik, can you make this full
Yes, sir.
screen and start your presentation? Good luck to you.
Thank you, sir. Good evening to one and all present here. I am Dr. Karthik, final year postgraduate student from KMC Chennai. I am here to present a carcinoma of tongue under the guidance of my HOD, Professor Dr. M. Parimala ma'am, and our unit chief, Professor Dr. Karthikeyan Sridevi ma'am. A 65-year-old gentleman from Tiruvallur, who is a lorry driver by occupation, belonging to lower socioeconomic status, presented with chief complaints of ulcer over undersurface of his tongue for past 2 months. Patient was apparently normal 2 months back, after which he noted an ulcer over ventral aspect of the left side of the tongue, which was insidious in onset, initially small in size, gradually progressed to attain the present size. History of pain over the site of the ulcer for 6 weeks, constant pricking type of pain, aggravated on food intake. History of difficulty in speaking for 6 weeks, history of excessive salivation for 6 weeks, history of difficulty in chewing for 6 weeks, history of left ear pain for 6 weeks, history of halitosis for 1 month. No history of difficulty in opening in mouth, no history of bleeding from the ulcer, no history of difficulty in tongue protrusion, no history of alteration of voice, no history of trauma to the tongue, no history of breathlessness, cough or hemoptysis. Past history, known case of type 2 diabetes mellitus on regular oral medication, not a known case of systemic hypertension, TB, epilepsy or venereal disease. History of tooth extraction done 10 years ago for dental caries. Personal history, consumes mixed diet, known alcoholic 180 ml per day, 2 days per week for 30 years, known smoker for 30 years, smoking index is 300. History of tobacco chewing for 40 years. History of beaten nut chewing for 40 years, mostly at night. No history of suggestive of promiscuous behavior. Family history, no significant family history. Summary, a 65-year-old male who is a chronic smoker, alcoholic, tobacco and betel nut chewer, presented with a painful ulcer over the ventral aspect of the left side of the tongue for the past 2 months, along with difficulty in speaking, chewing, excessive salivation and left-sided ear pain for 6 weeks. Shall I proceed?
Dr. Karthik. Go to the first slide, Karthik.
Yes, sir.
65-year-old gentleman, Tiruvallur, complaints of ulcer over the undersurface of the tongue for the past 2 months. History of pain over the ulcer for 6 weeks. What are the painful ulcers in the tongue?
A painful ulcer may be of benign etiology and the malignant etiology. It may be classified as ulcer. If it is a benign, long-standing painful ulcer, may be of aphthous ulcer. Then in carcinoma of tongue or oral cavity also pain may occur on late stages. Early stages it is painless.
Why in the early stages it's not painful? Why in the late stages it is painful? Carcinoma of the tongue.
Because of the ulceroproliferative growth, there may be necrosis and the formation of ulcers, sir. So there may be a irritation of the free nerve endings, and also the local pathogens, commensals in the oral cavity may cause a local inflammation, and it may lead to the pain of the free nerve endings, sir.
What are the painless ulcers that you know of in the tongue?
Painless ulcers may be of leukoplakia, syphilitic ulcer, TB ulcers, and chronic dental fittings causing ulcers.
Okay. Only for the past 2 months the patient is having ulcer in the tongue. That's also in the undersurface of the tongue, isn't it?
Yes,
What
yes,
is the
sir.
commonest site of malignant ulcer in the tongue?
Lateral border, sir.
Why it is very common in the lateral border?
Because
Not in
there
the
may be a
not in the yes.
yes, sir. There are prerequisites for causing the ulcers such as sharp tooth, spices, spirit, smoking, and sepsis, sir. So the lateral border of the tongue may be of site where these inflammations can occur.
Due to the sharp tooth, the injury to the lateral border is very common when compared to the other regions of the tongue. That is the main reason.
Okay, sir.
Isn't it?
I think
Any
is
other
the
reason?
tubercular ulcer painful or painless?
Sir, initially for 2 weeks it was painless, sir. Then for past 6 weeks it was painful,
No.
sir.
I'm asking, is the tubercular ulcers, they are painless or painful?
Sir, tuberculous ulcer are painless, sir.
No, the majority, that is the difference is there. No, that is, they are mostly painful. Yeah.
Okay, sir.
Painful ulcers.
Painful.
What is the characteristic edge of the tuberculous ulcer?
Punched out edges.
Punched out ulcer.
Punched out.
Tuberculous
Undermined.
ulcer.
Undermined.
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 Yes.
What are the various
Go to the
syphilitic
next.
ulcers which can occur in the oral cavity?
Sir, primary syphilis may cause canker, sir. And secondary syphilis can cause multiple ulcers over the oral cavity. And tertiary syphilis can cause gummatous ulcer,
Okay.
perforation in the hard palate.
Yes. Okay.
How it causes ulcer in the tongue? Syphilis.
Sir, there will be a endarteritis, sir. So due to the endarteritis, there will be a necrosis and the formation of, and the epithelium will get atrophied and there is a formation of ulcer, sir.
So which
type
kind of
epithelium?
edges, Karthik, which kind of edges will get in case of the syphilitic ulcer?
Syphilitic, there will be punched out edges.
Punched out edges. What is responsible factor for that? Why there is punched out edges in case of syphilis? Why there is undermined edges in case of tuberculosis? Why there is pearly white beaded edges in case of basal cell carcinoma? And why there is rolled out everted edges in case of the squamous cell carcinoma? Is there any explanation?
Sir, in squamous cell carcinoma, there will be an ulceroproliferative growth. So there will be central necrosis. Which can, there will be eventual sloughing of the floor, which give rises to the formation of everted edges in the squamous cell
Proliferation of the cell size is more common at the periphery. That's why.
periphery. Okay.
In tuberculosis, why there is undermined edges?
Bacteria may invade the subepithelium in the case of tuberculosis, sir.
Not subepithelium, subcutaneous tissue. Subcutaneous tissue is more prone for spreading the tuberculosis rather than the skin, and skin is resistant to the tuberculosis.
Okay, skin is resistant.
What type of epithelium you are having in the tongue?
Squamous cell epithelium, sir.
Keratinized, stratified,
Keratinized, stratified squamous epithelium.
Yes. Next slide. Issue of difficulty in speaking. What is the cause for difficulty in speaking?
The patient mainly complained of the difficulty in articulations of the speech, sir. Per se, he did not have a general difficulty in speaking. Because of the intrinsic muscle of tongue involvement, there may be a difficulty.
What are the intrinsic muscles of the tongue?
Longitudinal muscles, sir. Superior and inferior longitudinal muscle, transverse muscles, and vertical muscles.
Superficial. Right. Okay. Superior and inferior longitudinal muscles. Then
transverse and vertical. Transverse.
And
Vertical.
Vertical. Okay. What are the
Karthik.
four extrinsic muscles of the tongue?
So extrinsic muscles are genioglossus, um, uh, genioglossus, palatoglossus, styloglossus, ioglossus.
Hyoglossus. All these
Yes.
muscles are supplied by one nerve, except one muscle.
Palatoglossus, sir.
And
Palatoglossus is
hypoglossus.
supplied by the pharyngeal branches of 10th nerve, sir, whereas all the other muscles are supplied by hypoglossal nerve, sir.
What is the
Karthik.
number? Cranial nerve. Cranial nerve. Hypoglossal nerve.
12th cranial nerve, sir.
Okay, right. Why there is excessive salivation?
Sir, excessive salivation may be due to the ulcer may cause mucosal nerve ending irritations, and there may be a excessive parasympathetic stimulation, and there will be excessive salivation, sir. Or else, in case of advanced disease, there will be ankyloglycia, so that the patient can't salivate his own saliva,
What do you mean
swallow
by
his own.
ankyloglycia?
Sir, ankyloglycia is due to the involvement of the extrinsic muscles of the tongue. There will be a movement, restriction of movement in the tongue, sir.
Sorry,
What reason
Karthik, I
for-
want to interrupt you.
Okay, sir.
Karthik, what is nerve supply of tongue?
Sir, nerve supply is divided into anterior two-third and posterior one-third, sir. Anterior two-third is sensory innervation is a lingual nerve, and the taste innervation is by cauda tympani nerve.
Lingual nerve is the branch of? Is the branch of?
Sir, lingual nerve is a branch of trigeminal nerve, sir, mandibular division of the trigeminal nerve. And the cauda tympani is a branch of facial nerve.
Okay.
And the posterior one-third is supplied by the glossopharyngeal nerve, which is a ninth cranial nerve.
Okay,
Post,
good. Continue.
both sensory and taste.
Good,
Why there
continue.
is difficulty- Why there is difficulty in chewing?
Sir, actually, the intrinsic muscles of a tongue mainly help in the
What are the muscles of mastication?
sir medial pterygoid, lateral pterygoid, temporalis, and masseter.
These muscles involved.
Involved.
Then the patient will have difficulty in
Difficulty
chewing.
in
Why there is a ear pain? What is the
Sir,
concept behind that?
Okay,
In the case of painful ulcer or painless ulcer in the tongue,
in case of ulcer in the tongue, there will be irritation of the lingual nerve, which will be radiating to the aortic ganglion, sir. From the aortic ganglion, there through the cauda tympani to the aortic ganglion. From the aortic ganglion, there arises the auriculotemporal nerve, which supplies the external ear of the patient, sir. So there will be a radiating pain to the external ear.
what is halitosis? What is the definition of halitosis? And what is the reason for halitosis?
Halitosis is a bad breath of the patient, sir. Bad breath from the patient. It may be due to the retained food particle, or maybe due to the necrosis of the ulcer releasing the mercaptans and butyryl, sir.
Production of ammonia by the bacteria.
Ammonia. Okay, sir.
Yes, that is the reason for halitosis. Slide, next slide. Difficulty in opening a mouth is called what?
Trismus, sir.
What are the different causes of trismus that you know?
So the most common cause in the case of carcinoma oral cavity may be due to the pain, which causes the acute spasm of the muscles. So it may lead to the trismus, sir. Or maybe it may be the involvement or a pre-malignant conditions like oral submucosal fibrosis may also cause restriction in the mouth opening, sir.
What is quinsy?
Quinsy is the painful tonsillitis.
Peritonsillar abscess is called
Abscess,
quinsy. In that
peritonsillar
condition also you will have trismus, isn't it? Then temporomandibular joint involvement. You see a tongue like that. Then temporomandibular joint dislocation. Then fracture of the mandible. In all these conditions you will have trismus. What are the grades of the trismus? Having grade.
Mallampatti classification is there to grade trismus.
What is that Mallampatti? Grade
Restricted.
1, grade 2, grade 3, grade 4, 3.5 centimeter between
Yes,
the incisors, teeth, upper and lower, isn't it? 3.5, 2.5, 1.5, less than 1.5. These are the 4 grades, okay?
Okay.
Right. Issue of bleeding from the ulcer. Which type of ulcer you will expect the bleeding from the ulcer in the tongue? Which type of ulcer?
So malignant
Benign
ulcer.
or malignant ulcer? Huh?
Malignant ulcer may cause bleeding, sir. Due to the ulceroproliferative growth, due to the central necrosis and overgrowth of blood supply, there will be a sloughing out of the ulcer, and there will be a causing of bleeding from the ulcer, sir.
What else the issue of cough in a case of ulcer in the tongue?
Sir, in the case of ulcer in the tongue, the patient may be unable to take the foods or unable to swallow, sir. So there may be a retained food, or it may be due to the aspiration pneumonitis, which may cause the cough, sir.
Okay. What else the issue of alteration of voice?
Sir, actually, these oral cavity lesions are may cause synchronous and metachronous lesions.
What
So
do you
in
mean by
case of
synchronous? What do you mean by metachronous lesions? Definitions.
So synchronous is a lesion, secondary primary lesion, which arises less than 6 months from the other than that of the primary lesion, and the metachronous is greater than 6 months that arises other than the primary lesion. So in case of a posterior pharyngeal or the base of the tongue lesions, it may cause an alteration of voice.
What is the other name of the posterior 1/3 of the tongue? Base of the tongue. What's
Base of
that?
the base
Base
of
of
the
the tongue. Isn't it? Yes, come
Yes,
on.
sir.
Next slide. Diabetes mellitus, known case. Okay. CAD, CKD, not a known case. History of tooth extraction. In what way it is very important?
Sir,
Why is the history of tooth extraction in a case of ulcer in the tongue?
Sir, in case of recent tooth extraction, it is very significant, sir, because due to the involvement of the mandibular canal, there may be loosening of teeth and there may be extraction of tooth. But a long time history of tooth extraction is not those significance.
Why the recent tooth extraction comes very important? Why do you say?
It may be the involvement of the recent involvement of the mandibular canal, sir. Or the
What is the mandibular canal? Where it is present? Inside the mandible or outer surface of the mandible? Where it is present? Any idea about the anatomy of the mandibular canal?
Inside the mandible, it is usually present, sir. On the
What it contains that canal? Inguinal canal contains spermatic cord. Like that, mandibular canal contains what?
alveolar nerve, sir.
Which alveolar
Alveolar
nerve?
nerve,
Inferior alveolar or superior alveolar?
inferior alveolar.
Okay, next. Consumes mixed diet. Okay, alcoholic. In what way the alcohol is very important? Eliciting the issue of alcoholism.
Yes, sir. Alcohol causes both independent risk factor and also a synergistic risk factor, sir. In case of a independent risk factor, alcohol may be converted into acetaldehyde by the oral commensals, which may cause the DNA adduct damage and may lead to the carcinoma.
Not only
And in
that,
case
it
of
is less
synergistic
soluble.
effect, it may dissolve the sir.
Chemicals. Carcinogenic chemicals, isn't it?
Yes, sir.
Okay. In what way this
Yes, sir.
smoking is important in the case of ulcer
Yes, sir.
tongue?
Smoking. Yes, sir. Smoking nitrosamine compounds and polyhydroxy compounds, which may cause DNA adducts P53 deletion and may cause carcinoma of tongues, carcinoma of oral cavity generally.
What is nitrosamine? How it is produced? But it comes under the tobacco. In what way it is related to the tobacco chewing? Nitrosamines, chemicals, carcinogenic chemicals. Any idea about the nitrosamines?
No, sir.
No idea.
Nitrosamines are the carcinogens.
Nitrates are converted in tobacco contains nitrates. It is converted into nitrates by nitrate
Nitrous.
reductase enzyme by the bacteria present in the oral cavity. That
Okay, sir.
nitrates combine with the amines to form nitrosamines. This nitrosamine is a very carcinogenic chemical material. Okay. What is
Okay,
the
sir.
smoking index?
So smoking index is calculated by the number of cigarettes smoked per day into the number of years.
You have written 300. It's a good or it's a bad or in what way it is a
Sir,
this number?
greater than or equal to 300, there are high risk of causing malignancy, sir.
Okay, it shows high risk.
High risk, sir. Yes, sir.
In what way this betel nut chewing is related to the ulcer in the tongue?
Sir, actually, the betel nut chewing causes pathogenesis in three ways, sir. Chronic irritation, inflammation, and it itself is a carcinogen, sir. So in the chronic irritation and inflammation can cause oral submucosal fibrosis, which is a pre-malignant condition, and also it is a carcinogen which can cause DNA adduct damage and P53 deletion and can cause carcinoma, sir.
What is quid? QUID. What is quid?
So quid is a combination of betel nut, sarica nut, tobacco, dried leaves, and slaked lime. Yes, sir.
What is the action of
Indian
lime?
cancer?
Sir,
What is Indian cancer?
Indian cancer is buccal mucosa oral cavity cancer.
Why it's called Indian cancer?
So because these Indians usually have the habit of keeping the quid over the gingivobuccal sulcus, so it may cause oral buccal mucosa cancer, sir.
No history suggestive of what is that? Promiscuous
Promiscuous.
behavior. What is that behavior?
Sir, multiple sexual partners. Yes, sir.
Okay, in what way it is related to the tongue ulcers?
Sir, in multiple sexual partners, there may be a risk factor of contracting HPV, sir, viral DNA.
What variant? HPV virus. What is the number?
Sir,
16.
E6, E6, E7. Sir, 16 type and gene is E6 and E7, sir.
Okay, right. Then family history, no significant family history. Okay, right. Then next slide. Summary. Chronic smoker, alcoholic, tobacco, betel nut chewer presented with painful ulcer over the ventral aspect of the left side of the tongue, excess isolation, chewing, difficulty in speaking, left ear pain. By eliciting the history, the probable diagnosis. What could be the
this is a case of 65-year-old male with a chronic non-healing ulcer with radiating pain to the ear, which may be due to the malignant etiology. The ulceroproliferative growth may be of a malignant, and it is also a short duration, sir. And the patient is also predisposed to the risk factors.
What are the risk factors here in this particular patient?
So risk factors is a chronic smoker, alcoholic, and tobacco chewer.
Okay, all the three is there. Alcohol, tobacco, smoking, everything is there, isn't it?
Yes, sir.
Shorter duration. So what you are suspecting is a benign ulcer or malignant ulcer? What could be?
Sir, I need to further examine the patient to rule out whether it is benign or malignant.
Okay, right. By eliciting the history, what could be that ulcer?
It could be of malignant, sir. Probably a malignant.
Probably a malignant ulcer. You can tell that.
Probably.
Dr. Karthik, have you taken the history of HPV in this patient?
Yes, sir. Patient, I have asked for multiple sexual partner history, sir. The patient wife has no history of HPV or anything.
What is the difference between a non-HPV cancer and HPV cancer?
What are the differences between the ulcers?
HPV cancer,
usually it will affect anterior 2/3 or posterior 1/3.
Posterior 1/3 HPV is more common, sir.
Yeah. So oropharyngeal cancers are more common in the
more common, sir.
HPV.
Then, according to the stage, lymph nodes, what is the difference?
Lymph node staging varies, sir. Sir, in case of HPV, N1 is less than 6 centimeter, and N2 is multiple nodes less than 6 centimeter on the ipsilateral side, and N3 is greater than 6 centimeter.
No. What is the difference between HPV and non-HPV in the lymph nodes? Which one are bigger?
HPV might be bigger, sir.
Yeah, HPV are bigger. What about the prognosis?
Prognosis is good in comparison to the other squamous cell carcinomas.
HPV cancers have got the good, though they have got the big lymph nodes, they have the advanced stage, but the prognosis is good.
Yes, sir.
Okay. Yeah.
Yes, sir.
What is field cancerization?
Dr. Karthik, this is Dr. Sai. I just got a few questions for you.
Yes, sir.
Right. You said the ulcers on the undersurface of the tongue. Is it on the
Yes,
lateral
sir.
side? Right. So why is this area has a predilection
Ventral
for?
space.
Why does this area have a predilection for malignancy? Hello, Karthik, can you hear me?
Because the patient may yes, sir, yes, sir. Because the patient may have is a known tobacco chewer, which may cause chronic irritation over this area, sir. The ventral aspect and the lateral aspect.
So there's pooling of saliva, right? There is pooling of saliva, and that irritates the floor of the mouth and the lateral portion. What about the epithelium? Is there a different epithelium here from the rest of the oral cavity? Do you have an idea if the
It's
epithelium is different?
No, sir, same.
No, it is non-keratinized here. It's thinner and non-keratinized.
Okay, sir.
Right? So this has a limited barrier for carcinogens.
Okay, sir.
Okay. The second question which I have is that you said that there is synchronous tumors, right?
Yes, sir.
Less than 60. How many percent of these patients have synchronous, and how many percent have metachronous in oral cancers?
14%.
Do you have an idea? Excuse me?
10% to 14%. 10% to 14%, sir. 10%.
Synchronous.
Yes.
No, it's about 1.5% to 2%. And metachronous would be?
10%.
Metachronous.
10%.
Okay,
sir.
about it varies depending almost 10 to 40%.
Okay,
right?
sir.
So they within 5 years they can have that. Also about Lympadenopathy, like Sir said, it is in centimeters, but it is a more clinical way. You can
Yes, sir.
it is whether you can see the tonsillar fossa, you can see the
Uvula.
uvula, you can see the posterior pharynx. Okay.
Okay, sir.
Also in HPV, there is a difference, and that is it happens in an earlier age.
Okay.
Right?
Yes, sir. HPV is earlier age, sir.
Right. And like Sir asked you about the risk factors for malignancy, age is a very important risk factor. He may be having smoking, maybe alcoholic, having consumption of alcohol and quid, but age is also a factor, right?
Okay, sir.
It is
Karthik.
Yes, sir.
What is WHO definition of leukoplakia?
Leukoplakia is a whitish plaque or patch alkali as any other lesion, sir.
Complete definition.
Yes.
Dr. Karthik, ask you a few basic questions. What was the size of the ulcer to begin with, and how much is it now?
It was initially small, actually patient.
Small ulcer that attained its current size. We don't know what was the size earlier, and we don't know what is the size now. So if you could give us a rough idea, it will be good. And then this ulcer is present, you said, on the undersurface of the tongue. We don't know whether it is present towards the back of the tongue or towards the tip. We will get to know all that in examination, but it is good to cover it up in history also. Right?
Okay, ma'am.
And you said you said he's got difficulty in protruding the tongue, but there is no difficulty and there's no alteration in speech. So there are some very, very contradictory statements and incomplete statements that you've given, which you should correct.
Ma'am, there is no restriction in the protrusion of tongue, ma'am.
Yeah, so that's how, if you tell us the size, history of difficulty in speaking, right? Is it because of pain? Can you justify why is there difficulty in speaking?
It may be due to the intrinsic muscles of the tongue are used in the articulations while speaking, ma'am. So there may be pain in case of the ulcer.
Pain could be a restricting factor. Then did you tell us anything about the fact that if he's noticed swelling in any other part of the body, like neck or elsewhere? I may have missed it out. Did you mention it anyway?
No, ma'am. The patient No, ma'am. No,
Have
ma'am.
you mentioned it anywhere or not?
No, ma'am. No, ma'am.
It is very important to mention because this shows that you've seen a pathology in the mouth and you've limited your history and everything to that only, assuming that you're dealing with a malignant ulcer. So you must look for the site of primary if there's any evidence of metastasis elsewhere also or not. That should be covered in your history. What is the importance of asking for difficulty in breathing?
So maybe the aspiration pneumonitis, ma'am. Yes.
Yeah, good. Yeah, please carry on.
Karthik,
Yes, sir.
what are indication of surgeries for leukoplakia? What are the types of leukoplakia? What is erythroplakia? Because these are commonly asked in your PG exam, and these are the basic questions.
Okay, sir. Leukoplakia may be classified into homogeneous, nodular, and speckled leukoplakia, sir. In case of coming to the management,
and which
pre-malignant
leukoplakia is having more they are more prone for development of the malignancy?
speckled leukoplakia, sir. In case of speckled leukoplakia and upcoming induration around the lesion, and there is a non-homogeneous lesion, it may
What is
be
erythroplakia? What is erythroplakia?
erythroplakia is a red velvety lesion in the oral cavity, which may be not classified clinically or pathologically into any other lesions, sir.
What is incidence of malignancy in case of erythroplakia?
Incidence is around, leukoplakia, erythroplakia increases the risk factor about 17 times than the leukoplakia. 1%.
Please go through all these basic questions.
Okay, sir.
Continue.
Until differentiate between leukoplakia and candidiasis. Aditya.
Sir, in case of leukoplakia, it may be mostly unilateral, sir. Unilateral. Now, on candidiasis, there may be on the buccal mucosa, bilaterality may be present. Pain may be differentiating feature, sir.
Which one is wiped off? Can be wiped off? Candidiasis or leukoplakia?
Candidiasis will be wiped off, sir. Candidiasis is able to wipe off, sir.
That is the main answer we are expecting from you. Okay.
Okay, sir.
I think which leukoplakia are at more risk for the malignancy? Which leukoplakia are more risk for the malignancy?
So speckled leukoplakia, which is a non-homogeneous leukoplakia.
Yes.
A nodular leukoplakia also malignant, sir.
Yes.
There are 3-4 points, Karthik.
Size of leukoplakia.
Yes, sir. Greater than 200 millimeter square, and there is surrounding induration, sir.
Duration, age of the patient.
Duration.
And site.
Yes, a non-smokers and female gender.
Yes, so those are all the risk factors for the.
If you treat the leukoplakia by laser ablation, what is the disadvantage?
There may be recurrence, sir.
Recurrence. Laser ablation of the leukoplakia. You will not get any cells for histopathological examination.
Pathology is unreliable. Okay, sir. Okay,
and pathology is not possible. Leukoplakia. Okay.
Okay, sir.
Yes, right. What are the other pre-malignant lesions? One is leukoplakia, then other one is erythroplakia. You are told. Then any other?
Leukoerythroplakia.
Leukoerythroplakia.
Progressive verrucous leukoplakia.
Okay.
Progressive. Okay. Oral submucosal fibrosis. And
what is common cause for oral submucosal fibrosis? SMF, submucosal fibrosis.
So betel nut chewing.
Betel nut chewing.
Yes, sir.
Dr. Karthik.
Yes, sir.
This is Dr. Sahai. Okay, how do you manage leukoplakia? Suppose you have a patient who has leukoplakia. What do you do? How do you manage that?
Sir, we will manage based on the basis of dysplasia, sir. In the mild and moderate dysplasia, we will advise the patient to withdraw from the risk factors, sir. Most commonly, these patients will have intake of alcohol, smoking, and betel nut chewing.
One is removal of etiology. Next.
Next, there will be in cases of severe dysplasias, we will do CO2 ablation, laser ablation, or local excision, sir.
Okay. Anything else?
There must be surveillance in these cases, sir.
Okay. There is also cryo and electrode desiccation, and lycopene is sometimes helpful. You put them on lycopene.
Okay.
Retinoic acid. Okay.
Yeah.
Okay.
Right.
So shall I proceed?
What are the 6 S's related to ulcers of the tongue, malignant ulcer of the tongue? Any idea?
Sir?
6 S's usually they will ask.
Yes, sir. Sharp tooth, sepsis, spices, spirit, smoking. 5. Syphilis, sir.
Okay. In what way the spicy food will produce ulcers, malignant ulcer? Andhra people will take a lot of spicy food, you know that?
Yes, sir.
Yes. How it will produce malignant ulcer, spicy food?
It may cause irritation, sir. Irritation and local inflammation, which may cause a damage of the epithelium and formation of ulcer.
Okay, right.
Shall I proceed to examinations?
Dr. Karthik,
yes,
can you tell us something about oral submucous fibrosis?
Oral submucous is a chronic submucosal fibrosis condition in a case of oral cavity with predisposing factors in the people of taking betel nut chewing and tobacco chewing, ma'am. Here the patient will be having epithelial dystrophy, epithelial atrophy, ma'am, with just epithelial proliferation, fibrosis, fibroblastic reaction will happen, stimulated by areconin and tannin in case of betel nut chewing.
Right. So there is excessive collagen deposition. And it's the inflammation which it's just not seen on the surface itself. It goes beyond the surface epithelium. It goes into the muscles, and the collagen deposition or the fibrosis goes deep up to the buccinator, up to the level of your masticator muscles, which is the cause for your trismus. The soft, supple elasticity of the tissues is lost because of the extensive fibrosis, right? So classically, it is seen in the Indian population who are using tobacco. Apart from that, there are other conditions also. Many times you have patients coming to you with no history of tobacco chewing, and they complain of these things, something burning in the mouth and some kind of spicy thing they eat and it burns, but there is no tobacco history. So sometimes it can be due to some vitamin deficiencies. Okay, those are the other things. Vitamin B, vitamin C, and iron deficiency can also be a cause. And some of them are actually autoimmune patients. Okay, autoimmune conditions can also cause this thing. So it is an important cause for your trismus, right?
Okay.
One of the other pre-malignant conditions you seem to have missed out was lichen planus. Okay, lichen planus is also a chronic inflammatory condition, and patients diagnosed with lichen planus, it's a biopsy diagnosis, and they also must be monitored, right? For surveillance, they should be on surveillance. And you should know what is the rate of transformation in these cases. Can you tell me in the oral submucous fibrosis, what is the chances that it will transform into a malignancy?
I'm not sure.
So in 1.5 to up to 15%, you can have a malignant transformation. Okay, it can be up to 15% because it's a field change. it's not something you see in one part of the oral cavity. It's something you see in the entire mouth. Okay, what are the subsides of the oral? Can you tell us the subsides?
I don't get the question, ma'am.
Am I not audible?
Can you repeat, ma'am, please? Am I
Yeah,
audible, ma'am?
yeah. I said, what are the subsides for oral cavity malignancies? Am I audible?
Ma'am, it may be subsides. It may yes, ma'am. Yes, ma'am. Subsides. It may be of gingivobuccal sulcus, retromolar trigone, and there may be of a buccal mucosa, ma'am.
Yeah, there are 7 subsides, right? What defines oral cavity? What is the definition of oral cavity?
Oral cavity is from the lip to the anterior tonsillar pillar, ma'am. It does
Right.
not include. It only include a
What
hard palate.
borders of the lip? Lip means what borders?
Sir,
Vermilion borders, isn't it?
vermilion borders. Okay.
Anterior borders, vermilion borders. Then
Vermilion
posterior?
borders. Posteriorly up to the anterior tonsillar pillar, sir, which is a junction between the hard palate and soft palate.
Soft palate.
The junction between the hard palate and soft palate is oropharynx, sir. Does not include in oral cavity.
Laterally?
Laterally buccal mucosa.
What are the borders of the buccal mucosa? Anteriorly, posteriorly, above and below.
Anteriorly, it is till the lips, sir.
Commissures
Of the lip. Anterior and
above
it is hard palate.
gingivobuccal sulcus.
Gingivobuccal sulcus.
Lower
gingivobuccal sulcus.
Posteriorly
up to the anterior tonsillar.
trigone.
Ramus of the mandible.
Okay. What are the subsets? 7 subsets. You are not told. You are not asked to the madam.
Glossotonsillar fossa, labial sulcus, gingivobuccal sulcus, gingivotonsillar sulcus.
Flora of the mouth.
Floor of the mouth.
These are the things.
Please look up the subsides, okay? The 7 subsides, you have to remember it the way it is. Okay, it's floor of mouth, anterior 2/3 of tongue, buccal mucosa, it's a hard palate. These are the ones that form the subsides. Okay, so the point what I was trying to make here is in your submucous fibrosis, it's not something you see in one part of the oral cavity. It's something you see in both sides of the buccal mucosa, in the retromolar trigone, in the gingivobuccal sulcus. It's a kind of a field cancerization. Do you know what is field cancerization?
Yes, ma'am. Field cancerization is a generalized exposure of the carcinogen to the wherever it is exposed, ma'am. It may cause synchronous and metachronous lesions.
So, which are the fields we are looking at here?
We are looking at the buccal mucosa, tongue, floor of the mouth, and the palate and the oropharynx, posterior third of the tongue.
So, any area that is lined by your squamous epithelium is at a risk. Okay.
Aerodigestive tract.
Yes, it is the aerodigestive tract. So even your larynx, your bronchus, your esophagus, all these will be at risk, right? For CA. Yeah, this is what I wanted to know.
In which group of people, malignancy of the hard palate is very common? In which group of people, malignancy of the hard palate is very common? Are you able to understand my question?
Yes, sir. Yes, sir. Yes, sir.
Yes.
In the nasopharyngeal cancers.
What type of smoking? That's called reverse smoking.
Reverse smoking. Okay.
In that group of people, the cancer or malignancy of the hard palate is very common. Okay.
Okay, sir.
Right. All over the world or in the Western people, which malignancy is very common in the oral cavity And in India, which malignancy is common and why?
In India, buccal mucosa is very common, sir.
Yes, I already told that. That is Indian cancer. All over the world, or even
All
Western
over
people. In
Western people,
America
it may
and
be a
United
lip
States, are
cancer.
very common. Lip,
Lip
not
cancer,
lips.
sir.
Tongue cancer.
Tongue,
Tongue
sir.
cancer is very common because smoking is very common there, you
Okay,
know.
sir.
Yes. We are using tobacco, especially in the lower gingivobuccal
Close.
sulcus, we are keeping as a quid. That's why Indian cancer is very common here. That in this area, there, because of that smoking, they are
Smoking.
having carcinoma. Okay?
Okay,
Yes.
sir.
Go to the examination, clinical examination.
Okay, sir. The patient is conscious oriented, hydration fair, moderately built and nourished. ECOG score of 1 and Karnofsky score of 90. BMI is 26 kg per meter square. No pallor, icterus, sinuses, clubbing, and pedal edema. Vitals pulse rate 89. BP 130/80 measured in sitting position in left arm, and temperature is normal. Respiratory rate is 18 per minute. Inspection patient examine the sitting position in the daylight with the proper exposure and with informed consent. Lips no pigmentation, ulcer or growth. Commissures no angular cheilitis. Mouth opening adequate. Nicotine staining present. Poor oral hygiene. Halitosis is present. Dental formula is given. This is
Okay.
the
Dental
this is
formula.
the yes, sir. Picture of the ulcer in the ventral aspect of the tongue. 3 cross 3 centimeter noted in the ventral aspect of the tongue with irregular margins and everted edges. Slough over the ulcer present and extending anteriorly 1 centimeter from the tip of the tongue, medially crossing the midline for about 0.5 centimeter and laterally to the lateral border of the tongue. Posterior 2 centimeter from the floor of the mouth. No bleeding, no restriction in movement of tongue, no deviation of tongue on protrusion. Palate, no ulcer, swelling or perforation present. Gums, no ulcer, growth or swelling. Buccal mucosa, no leukoplakia, no pigmentation, no ulcer or growth. Floor of mouth, normal. Retromolar trigon, normal on both sides. Lips, soft, no palpable lesions. Tongue, inspectory findings were confirmed. Tenderness present. An ulceroproliferative lesion of size 3 cross 3 centimeter involving the ventral aspect of the and the lateral border of the tongue with irregular margins and everted edges extending anteriorly 1 centimeter from the tip of the tongue, medially 0.5 centimeter crossing the midline, laterally extending to the left lateral border of the tongue, posteriorly 2 centimeter from the floor of the mouth. Induration could be felt crossing the midline medially for about 1 centimeter and about 1 centimeter from the floor of the mouth posteriorly and laterally extending to the left dorsum of the tongue for about 1 centimeter. Base of the ulcer is indurated. Ulcer does not bleed and touch. Floor of mouth is free. Retromolar trigon is normal. Gums no thickening is present. No evidence of thickening of mandible. Gingivobuccal sulcus is normal. Examination of neck. A well-defined swelling of size 2 cross 2 centimeter present palpable in the left submandibular region. Non-tender, firm in consistency. Well-defined, mobile. Systemic examination, no other lymph node palpable. Systemic examination, CVS S1 S2 RS bilateral air entry present, per abdomen soft, CNS higher mental function normal. A 65-year-old diabetic male who is a chronic smoker and alcoholic, tobacco and betel quid sugar presented with painful ulceroproliferative lesion with surrounding induration over the ventral aspect of the left side of the tongue, which crosses the midline and along with the palpable left level 1B lymph node. My provisional diagnosis would be a case of carcinoma of tongue with clinical staging of T2N1 and M2PT6.
Very nice presentation, Karthik. But you are not told about any about this opening of the submandibular duct in the floor of the mouth. Have you mentioned that?
No, sir.
No. What is the name of that duct?
Wharton's duct.
What is the length of that Wharton's duct and where it opens?
It
Your case
opens in
is
the
under
bilateral.
surface of the,
In the under surface of the tongue, in the both sides of the frenulum, sir. It opens in the both sides of the frenulum.
Your case
It is
is
from the sub.
ulcer is in the under surface
Yes.
of the tongue, isn't it? But
Yes,
you should
sir.
mention about that, isn't it? What
Yes,
is
sir.
this tension duct? You
It's
have
the
not mentioned
opening.
about that duct also.
Parotid duct opening in the second upper molar, opposite to the crown of the second upper molar tooth, sir.
Have you examined?
Yes, sir.
Have you looked for?
Yes,
Yes.
sir.
Complete thorough examination of oral cavity is very, very important.
Okay,
Okay.
sir. Okay, sir.
By eliciting this all findings, what's your probable diagnosis?
Uh,
Malignant
well,
ulcer.
yes, sir. Malignant ulcer with a node palpable level 1B node, sir. 1A.
What are the points in favor of your diagnosis of carcinoma, malignant ulcer of the tongue? Why can't it be a benign ulcer?
Sir, on examination, there is a induration present, sir, surrounding the ulcer. The base of the ulcer is also indurated, and there is also a clinically palpable node on the left side of the level 1B, sir.
Is it a
Rolled out
significant
ever.
node or insignificant node? What is the difference between these two? What is significant lymph node?
Significant
What is
node.
insignificant lymph node? What are the characteristic features to say that it is a significant node?
Sir, significant node is one which is greater than 1 centimeter, sir.
Yes.
Uh, with a loss of which is in imaging investigation there is a loss of fatty ileum.
Yes. Clinically, I am asking. It should be hard in consistency. Rounded.
Okay, sir. Rounded, hard in consistency, immobile.
Yes.
Mobility restricted, sir.
Okay.
Mobility restricted.
Clinically, it is T2N1MX. What do you mean by T2?
Sir, T2 is a condition, it's a ulcer 2 to 4 centimeters, sir.
Okay.
And any.
What is N1?
Sir, M1 is a metastasis to the distant organs like lungs.
N1 means nodes, isn't it? Distant metastasis. M for metastasis. N1, I am asking.
N1, sir. Okay, sir. N1 is a node which is less than 3 centimeter with no S nodal extension, and N2 is further classified into N2A, N2B, and N2C, sir. N2A is 3 to 6 centimeter on ipsilateral side, and N2B is multiple ipsilateral nodes 3 to 6 centimeter, and N2C is contralateral node involvement less than 6 centimeter, and N3 is classified into A and B, sir. Which is N3A is greater than 6 centimeter lymph node, and N3B is the extranodal extension, sir.
What's the differential diagnosis? You want to offer any differential diagnosis of this ulcer?
Applicate.
Yes, sir.
Why can't it be a amelanotic melanoma, malignant melanoma?
Because there is no family history.
Why can't it be an adenocarcinoma? Usually it will be a squamous cell carcinoma, okay?
Yes, sir.
Adenocarcinoma, if it arises from the oral cavity, what could be the reason? What are the cells of origin?
Salivary glands, sir. Minor salivary glands may cause adenocarcinoma.
Okay.
Adenocarcinomas.
Okay. How will you proceed?
Sir,
I will confirm the diagnosis.
Yes, sir. I will confirm the diagnosis by taking the punch biopsy at the edge of the lesion. And for the
Why are you taking from the edge, not from the center?
In case of center, there will be a necrosis and sloughing out, and there will be no yielding of the good malignant cells, sir. So, where the vascularity is higher, active proliferating cells in the edges. So, we are taking the biopsy from the edges, sir.
Which edge? Anterior edge or posterior edge? Which edge you will take usually from the ulcer? Usually it should be taken from the anterior edge, okay, of the ulcer.
Okay, sir. Okay, sir.
Okay. Then how will you stage?
For staging the disease, I will do the imaging studies, sir. For imaging studies, we can routinely do MRI head and neck. If not available, we can do CT head and neck, sir. And for
bone involvement, which investigation is better? For soft tissue involvement, which investigation is better?
For soft tissue, it is MRI, sir. And for bone involvement, it is CT, contrast and CT.
Okay. Then any other investigation you want to do?
Sir, I will look for metastasis workup like chest X-ray. And in case of smoking history and risk factor is very high, I will do CT chest, sir. Then I will do for the node. If it is a significant node, I will do FNAC of the node, sir. USG guided FNAC. Then orthopentagram can be done.
What does it mean by significant node?
Significant node is in imaging is loss of fatty alum. There will be loss of fatty alum in the imaging, sir. And in clinically, if it is greater than 1 centimeter node, it is a significant node, sir.
What is lymphatic drainage of tongue?
Sir, tip of the tongue is usually drained into the submental lymph nodes, sir. Whereas the anterior 2/3 of the tongue and the posterior 1/3 are anterior 2/3 of the tongues are drained into the level 1 to 3 nodes, and from there to the deeper cervical nodes. Whereas the posterior 2/3 of the tongue is drained to the bilateral lymph nodes of 1 to 3.
What are different types of lymph nodes in the neck? Different lymph nodes, level 1, level 2, level 3.
Yes, sir. Level 1 is a submental lymph nodes. 1A, 1B is submandibular. Level 2 is upper jugular, middle jugular, and lower jugular, jugular digastric nodes, and jugulo-omohyoid nodes.
Which one is called a jugulo-digastric node? Which one is called a jugulo-omohyoid node?
So jugulo-digastric is usually a level 2 and 3, sir. And
level 2 is called jugulo-digastric. Level 3 is called jugulo-omohyoid.
And level 5 is posterior triangle nodes. 6 is sir.
Okay. Edge-wedge biopsy report is coming as a squamous cell carcinoma of the tongue. How will you proceed? That node you are taken from the submental or submandibular, left side or right side? Left side.
Left side submandibular node, sir.
Okay, right. That also shows malignant cells, secondary metastatic deposits. How will you proceed?
Sir, initially I will present in the multidisciplinary forum, and I will involve the patient for the adequate psychological counseling for that the patient may require a reconstruction and physiotherapist, and I will then proceed to assess fitness for the surgery. Then I will proceed for the surgery, sir, because all the squamous cell carcinomas in the oral cavity, if it is resectable, we will first initially do surgery.
What are the various types of glassectomies that you know of? Surgeries on tongue.
Yes, sir. Hemiglassectomy, compartmental hemiglassectomy, subtotal glossectomy, near total glossotomy, and total glossectomy, sir.
What is the hemiglassectomy?
So hemiglassectomy is a great removal of wedge-shaped or region of the one side of the tongue, whereas compartmental hemiglassectomy is the removal of the half of the tongue on the ipsilateral side, whereas subtotal glossectomy is the removal of the anterior 2/3 of the tongue, and the near total is removal of the ipsilateral anterior 2/3 and posterior 1/3 and contralateral 2/3 of the tongue, sir.
Okay, in your particular case, what surgery you are going to do? What type of glassectomy you will prefer?
Sir, the lesion is moving, crossing the midline and involving the contralateral side, and there is also induration. So I will probably do a subtotal glossectomy, sir.
Along with, how will you deal with the nodes?
Sir, I will do the ipsilateral modified radical neck dissection, and contralateral, as it is crossing the midline, I will do contralateral supraomohyoid selective neck dissection, sir.
So modified radical neck node dissection on the left side and supraomohyoid neck node dissection on the right side.
Right side, yes, sir.
Okay. You have removed the anterior 2/3 of the tongue. That is, you have done subtotal glossectomy. How will you reconstruct?
Sir, free flaps, we can reconstruct the tongue using the flaps. Flaps may be classified into free flap and a pedicle flap, local flaps. So in this case, I will use free flaps, sir. Anterolateral.
What type of free flap in your government medical college, KidPop, they are doing? Chennai.
They most commonly do radial free free forum flaps, sir.
Forearm free flap.
Forearm free
Means
flap. Forearm free flaps.
Dr.
Okay.
Karthik, I just want to ask you something. What is the importance of depth of invasion? Will it affect your management?
Sir, depth of invasion affect nodal stages, sir. In case of clinically no negative nodes, if the depth of invasion is greater than 4 mm, there will be a possibility of occult metastasis in 30% of cases, and it also affects the prognosis of the patient, sir.
Right. So it doesn't affect your management, right? But it affects your prognosis.
Yes, no, sir. Prognosis, sir.
Okay. Yeah. Good.
So,
Tell me
Dr.
some incisions for neck node dissection that you know.
Sir, McAfee incision, hockey stick incision, Kryle's incision. Yes, sir.
What are the complications of modified radical neck node dissection?
There may be a formation of hematoma or a lymphedema, seroma, sir. Seroma is most common, and infections, post-operative infections. And there may be a damage of spinal accessory nerve, sir.
Then necrosis, skin necrosis is very
Sick neck.
common.
Okay, sir.
Spine necrosis one. Okay. If you are not treating this patient, carcinoma tongue, how the patient will die?
Sir, there will be epiglottis edema and aspiration.
Carotid blowouts. What do you mean by carotid
Carotid
blowouts?
blood. Encasement of the internal carotid artery, which may cause carotid blood, sir. Erosion and encasement.
Cachexia, carotid blowouts, all these things.
Okay.
The patient will die. Okay. What do you mean by type 1, type 2, type 3 modified radical neck node dissection?
Sir, in type 1 modified radical neck node dissection, spinal accessory nerve is preserved, sir. In type 2, spinal accessory nerve and interjugular vein is preserved, whereas in type 3, spinal accessory nerve, internal jugular vein, and the sternocleidomastoid is preserved.
What do you mean by functional neck node dissection? All these three.
Functional, selective is sir.
No, selective is completely different. This one is a functional neck node dissection. All these three non-lymphoid structures are preserved. That is called functional neck node dissection. Why particularly these three structures should be preserved? Sternocleidomastoid muscle, spinal accessory nerve, and internal jugular vein. What is the purpose? What is the concept behind that?
Sir, to decrease the post-operative morbidity in these cases, sir, in case of spinal accessory nerve, if it is damaged, there will be a trapezius muscle will not be functioning, and there will be no stugging of frozen shoulders. Frozen shoulder,
yes, good. To avoid that, spinal accessory nerve we are preserving. Then why you are preserving this one, sternocleidomastoid muscle? For cosmetic purpose. Internal jugular vein. Okay, to avoid venous edema of the face. Okay? Right. What are the indications for radiotherapy in carcinoma tongue?
Yes, sir. Post-operatively, if there is a margin positivity, major indication, and if there is an extranodal extension, sir, and the minor indication, there are multiple lymph nodes, and T3, T4 lesions, sir.
Yes, T3, T4, very large lesions. You have to give radiotherapy. For T1 lesion, which one is better, wide local excision or radiotherapy, and why? If you are becoming consultant in 3 months' time, which one you will prefer? The patient comes to your clinic. Radiotherapy or wide local excision?
Wide local excision. Wide local excision I will prefer, sir. Because in case of squamous cell carcinoma of tongue, surgery is the mainstay of option, sir. If the patient is not willing for surgery, or if the patient is debilitated to surgery, we will try for primary radiotherapy, sir.
You have told something about the supraomohyoid lesion. What are the supraomohyoid neck node dissection? What are the levels of nodes that you are going to remove in supraomohyoid neck node dissection?
1, 2, and 3, sir.
Level 1, 2,
level 2, and level 3, sir.
What do you mean by lateral neck node dissection?
Lateral neck node dissection is 2, 3, and 4.
What do you mean by skip metastasis?
Skip metastasis if the Metastasis goes to level 3 and level 4 nodes without involving the level 1 and second nodes, sir.
Okay, almost all questions you have answered. Very nice presentation.
Karthik, I want to ask one question. What is the role of radiotherapy in treatment of N0 neck?
Sir, I can't hear.
What is the role of radiotherapy in treatment of N0 neck?
Sir, N0 neck, it is to treat occult metastasis, sir.
Okay.
Dr. Karthik, if the ulcer had not crossed the midline, how would you have addressed the neck then? You said 0.5 centimeter across the midline. So if it had not crossed 0.5 centimeters, would you have addressed the neck differently?
No, ma'am, it doesn't alter the management.
So what is the reason why you should do supraomohyoid on the opposite side?
Because the ulcer has crossed the midline, we are doing contralateral supraomohyoid.
Even if it is not crossing,
we will do ipsilateral dissection.
No, you will still do supraomohyoid on the other side because there is this churning effect of lymphatics which is there in the tongue. So which can take malignant cells to the opposite side. So tongue is one area where you would still address the neck on the other side. And plus, I would want to say that you should tell the margins of the ulcer very clear, the extent of margins clearly. You said posterior border is as many centimeters from the floor of the mouth.
Yes, ma'am.
Which makes it very unclear. What you floor of the mouth is an area, no? So you should be able to tell it with respect to sulcus terminalis.
Okay.
Because that's how the anterior and posterior parts of the tongue would be defined.
Okay.
Nice presentation, Dr. Karthik.
Very well presented.
Thank you, sir. Thank you.
You answered most of the questions.
Thank you, sir.
Karthik, you can unshare your screen. Do you have any doubts to be clarified?
No, sir.
Okay, good luck to you.
Thank you.
Give my kind thanks to Madam also. I'll speak to her in the morning.
Okay, sir. Sure.
Abhilash, please unshare. Abhilash, are you here? Please switch on your video, Abhilash. Make it to full screen, Abhilash. Are you able to hear us, Abhilash? We are unable to hear you, Abhilash. Faculty, others, are you able to hear him?
Okay.
Hello, sir.
Abhilash, I recommend you to log out and re-log in. You have, if you are using a headset, remove the headset from the system. Are you able to hear us, Abhilash? Abhilash, do something what I'm telling. You remove your headset from the system. If you're using Bluetooth or cable, please remove it. Log out now and re-log in. Sorry for the inconvenience.
Hello, sir. Hello. What is this? Hello, sir.
Hello, sir.
Yes.
Yeah, you are fine now.
Sir, is this okay? Yeah. I just want to.
We are able to hear you, Abhilash, but we are unable to see you or the presentation.
Yes, sir. Just sharing it right now. Sorry.
Okay.
Sir, is this visible, sir?
No, slides are visible. Only thing is we are unable to see you.
Oh.
Your audio is good now.
Okay, sir. Just.
Please see to enable the
I
video.
can see Abhilash. Yeah. Yeah, presentation.
Am I
Yes.
visible now, sir?
Yeah, you are good.
Yeah, you are good.
Make it full screen. Start the presentation. Good luck to you, Dr. Abhilash.
Okay, thank you, sir.
Please
I'm
introduce
very
your
sorry for the delay.
chief, head of the department, and start your presentation.
Yes, sir. My name is Dr. Abhilash. I'm a junior resident from Department of General Surgery from Government Medical College. And my HOD and my guide here is Dr. Srijan MP, sir. He's the superintendent of our hospital also. And I extend my special thanks to my unit chief, Dr. Priya Radhakrishnan madam. And I'd just like to start my presentation. Presenting a case of 47-year-old female who is coming from Gudalur, who is a manual laborer by.
Could you move your slide?
It is not.
Go to full screen and move, then move. Yeah. That's it. Okay.
Is it better, sir? No.
Well, it's not slideshow, but okay. Go on. Go on.
This female, she presented with the complaints of fever and malaise for 1 month, and swelling in the left side of the neck for 3 weeks, swelling in the left axilla for 2 weeks. I'm very sorry. I think something is wrong. I'm not able to share it properly.
Yes. Negative is training. It can be. It can be.
Is there any other?
Abhilash, it would be better to go to slideshow and then share.
Yeah, sir, I'm trying it, but I'm not able to share it properly.
Okay, let's get on with it.
Do you have anyone to help you, Abhilash?
No,
None of your friends are there nearby?
Yes, sir. Right, can I just once more just log out and just try? Very sorry for the delay. I had been attending the thing.
So learn to listen, Karthik. No, remove all your headsets and all that you are wearing.
All right, Abhilash, you
Remove all
just
this from your laptop.
stop
Dr.
doing
Annabelle
anything.
Sir has been telling
Just
you.
stay there. I've arranged to show up the PowerPoint for you. When you're presenting, you keep a couple of friends along with you. If you have stressed out of the case, they can help you with the technical things.
Now you log out and re-log in.
Okay.
And when you start your computer, you minimize your PowerPoint presentation and keep it there.
இன்னும் வரலையாண்ணா ஸ்டார்ட் பண்ணு நீ வர இடத்துல அங்க போய் உட்காந்துக்கோ நம்ம ட்ரெஸ்ஸிங் ரூம் சைடில் இருக்கிற கிளிப் அங்கே கனெக்டிவிட்டி இருக்கும் You help him to present one slide at a time. Abhilash, you start presenting, Abhilash. Can you unmute and start presenting, Abhilash? I've asked one other PG to help you to present forward the slides. The slides are already on the screen. You please start presenting. She'll be able to advance the slides.
Okay. So there were some changes in the slides, sir. So we'll just go on with the presentation. I'm very sorry, I
You
don't
please
know.
present with the slides, Dr. Abhilash. We want the class to happen.
Okay, sir. Sorry.
You can tell the additional points, whatever amended on the respective slides. No problem at all. Faculty here can understand easily.
Okay, sir. Thank you. So presenting a case of 47-year-old female who is coming from Gudalur. She is a manual laborer by profession. She presented to us with the complaints of fever and malaise for 1 month duration, and swelling in the left side of the neck for 3 weeks, and swelling left axilla for 2 weeks. Patient was apparently well 1 month back when she developed fever, which was of continuous nature and subsided only on taking medications. She had associated malaise and fatigue associated with night sweats. She noticed a swelling in the left side of the neck after 1 week of developing fever, which was initially small in size, which rapidly increased in size over the next 3 weeks to reach the present size. She noticed other similar swellings on the same side of the neck and also in the left axilla, which increased in size over the past 2 weeks. The swellings were not associated with any skin changes, ulceration, or redness, and are not associated with pain. She had history of vague abdominal pain, predominantly in the umbilical region, 1 month back for a duration of 2 days, for which she had consulted the local hospital and took medications. Over the past 5 days, she is complaining of difficulty in swallowing feeds, which are both solids and liquids, but is not associated with vomiting. There is no history of any regurgitation. Coming to the negative history, there is no history of loss of weight, no history of loss of appetite, no history of any breathing difficulty, cough, chest discomfort, or hemoptysis, no history of abdominal distension, altered bowel habits, melena, or jaundice, no history of backache or bone pain, no history of any change in voice, no history of ear pain or ear discharge, no history of nasal discharge. Coming to the past history, there is no history of any similar illness in the past, no known comorbidities like diabetes mellitus, hypertension, bronchial asthma, no history of tuberculosis in the past, no history of any contact with a person with tuberculosis, no history of prior surgeries, no history of previous blood transfusion, or no history of any radiation exposure. Coming to the family history, she is the youngest of 5 children from a non-consanguineous marriage. She has a history of breast cancer in the eldest sister, and she died of complications from the same. The second eldest sister died of complications from COPD. No further details were available. No history of any other malignancy in the family. Coming to the personal history, she takes a predominantly non-vegetarian diet. Appetite was adequate. Sleep noted to be increased over the past 1 month. Bowel and bladder habits are unaltered. History of bitter nut chewing for past 6 years, with occasional use of tobacco. No known drug allergies. Coming to the menstrual and obstetric history, she attained menarche at the age of 13 years, had a normal cycle of 28 days duration with flow of 4 days, married at the age of first child at the age of 19, had 2 children, both full-term normal vaginal deliveries, and children were adequately breastfed. She is divorced for the past 20 years. Last menstrual period was 9 months back, owing to the perimenopausal age group. There is no history of any high-risk behaviors. Coming to the socio-economic status, according to modified Kupasamy scale, he has a score of 7 and belongs to upper lower socio-economic status. So this next slide is general exam. So hello.
Go to the first slide, Abhilash.
Okay. Please choose the first.
Oh, you can.
Yeah, sorry, sir.
Right. Next. What is the presenting complaint? Fever, 1 month, swelling left side of the neck, 3 weeks, swelling in the left axilla, 2 weeks.
Yes, sir.
Okay, next. Why particularly in this patient?
Yes, sir.
Night sweats is there. What do you mean night sweat?
So night sweats is
Usually in
when,
the daytime we will have sweat. Why this
yes,
particular patient is having night sweat? What do you mean by that? What do you want to tell us?
the patient is having a continuous fever and she is taking medications for it. And during sleeping, she is having a change in the temperature which is causing her to sweat. And this sweat is causing drenching and she is waking up in between the sleep because of being drenched. So that is what
What
I
would
mean by
be
night sweat.
cause, surgical cause for night sweats? Or any cause? Etiological factor, night sweats.
Because of the fever persisting continuous, in case of, in this patient, she had a continuous fever which was subsided only on taking medication, sir.
Continuous fever, even in the night the patient is having.
Yes, sir.
Okay, right. Next. Next. Yes. First swelling in the left side of the neck or in the right side of the neck?
Left side of the neck itself, sir. She
Left
didn't
side.
notice the swelling in the right side of the neck. She noticed the swelling in the left side of the neck, which
It's
was
not
after 1
associated.
week of developing the fever.
No issue of any itching, no skin changes, no ulceration, no redness, nothing.
No, nothing
Only
was there.
1 month period.
Yes, sir.
Yes.
She
Yes.
developed the
Next.
swelling.
Next. Why the patient is having a vague abdominal pain, night
Uh,
sweats, and vague abdominal pain? What could be the reason for that?
Sir, according patient with the vague abdominal pain could be a lot of reasons, but this patient, the pain was there for only a duration of 2 days. And she was taking a lot of NSAIDs, so I probably think that it is because of NSAIDs induced gastritis in this patient. She had taken a lot of NSAIDs and that caused vague abdominal pain, just in the upper abdomen only, predominantly. She had taken medication and it subsided.
What could be the reason for this difficulty in swallowing
Yes, sir. She
both the
developed.
solids and liquid feeds?
Yes. So this patient has developed swelling in the left side of neck, which is probably a lymph nodal swelling. And similarly, she is having an axillary swelling, which can also be a lymph nodal swelling. So again, I am suspecting lymph nodal enlargement in the mediastinum, which is causing
This
compression leading.
axillary swelling will make the patient having difficulty in swallowing.
No, sir. No,
Is
sir.
there any relation between these two?
No, sir. Because of the generalized lymphadenopathy, the patient can develop a mediastinal lymph nodal enlargement also, which can present with dysphagia as difficulty in swallowing feeds both liquids and solids.
Mediastinal mass compressing the esophagus, you want to tell us.
Yes, sir.
Isn't it?
Yes, sir.
No regurgitation. Okay, next slide. No issue of loss of weight. No issue of loss of appetite. Okay. No issue of ear pain. No issue. Why do you accept the issue of nasal discharge?
Sir, in this patient, the patient is having a swelling in the left side of the neck, which is a cervical. Considering it to be a lymph nodal swelling, it could be we should ask for history of draining sites, which could be the paranasal sinus and nasopharynx. So the patient can present with complaints of sinusitis and nasal discharge. That's why I asked.
Why you accept the issue of change in voice?
Change in voice again, sir. Patient can because owing to the draining sites, I asked because it could be a thyroid mass which can cause infiltration of the recurrent angina nerve, or a nodal swelling which can cause again infiltration of the recurrent angina nerve, causing a change in voice. And also because
Involvement of recurrent laryngeal nerve will cause what type of voice? Huskiness of voice or hoarseness of voice?
husky voice will be there.
Huskiness. Huskiness of voice is due to the injury to the external branch of the superior laryngeal nerve. Here you will have hoarseness of voice. Okay. Why you elicited the history of altered bowel habits?
Sir, I wanted to, like, considering the left side of the neck, it is a training site of multiple sites, including the GIT. So I have asked for abdominal distension, altered bowel habits, and also considering a possibility of tuberculosis in my patient.
What is the name of the node in the present in the left supraclavicular region?
Node, sir.
What is that sign called?
Proceus sign, sir.
Proceus. Okay. Next slide. Past history. No issue of tuberculosis. Why you also the issue of tuberculosis?
So, considering our country, the most common cause of multiple lymph node swelling is first diagnosis should be TB. I mean tuberculosis. So that's why I asked for any history of past tuberculosis, which can lie latent and then get reactivated, or a history of any contact with a person with tuberculosis in the recent period.
What type of fever you will have in tuberculosis?
In tuberculosis, we'll have a evening rise of temperature will be there, which is characteristic of tuberculosis.
Why you also the issue of a previous blood transfusion?
Blood transfusions. So, sir, considering the patient having multiple lymph nodal swelling, I wanted to rule out the risk of being immunocompromised, and the previous blood transfusion and prior surgery history can suggest the patient contracting a disease of HIV/AIDS or hepatitis B, which can all lead to immunocompromised.
HIV related diseases. Good. Slide. Next slide. Issue of breast cancer.
Yes, sir.
Died of complications from the same.
Yes.
What do you mean by complications of the breast cancer? What complication?
She had taken, she had undergone an MRM, and then she completed the course of chemotherapy. Her sister. Then after 10 years, she developed a recurrence, and that recurrence was full with metastasis to the liver, and then she died of complication. That is what they told. Because of the complications, she was unable to take treatment the second time it occurred.
This patient, particularly your patient now at present, this patient is having any lumps in the breast? Have you elicited the history?
I did not ask. I have done an examination in the examination part. I have mentioned, sir, not in the history. I have mentioned that there is no swelling elsewhere. Like she didn't say.
Pre-menopausal lady or post-menopausal lady? This patient.
Perimenopausal. 47 year old. She's having. She had her periods. Last menstrual period was 9 months back. So in the perimenopause, yes.
Next. What do you mean sleep increased over the past 1 month? What do you want to tell us?
Considering a probable diagnosis of a lymphoma, also there is multiple. So there is B symptoms, which could be fatigue, then night sweats and fever. So owing to the weight loss and night sweats and fever, owing to the continuous fever, she is having easy fatiguability and also malaise, and she is complaining that there is increased sleep. She is unable to wake up from the bed because of the fatigue.
Pond chewing for the past 6 years, sir. What do you mean by pond chewing?
Sir, it was betel nut chewing, sir. I had changed pond chewing, sir.
With the occasional use of tobacco also.
Tobacco, yes, sir.
Okay. Is she having any ulcer history in the tongue or in the oral cavity? Any substance?
No complaints of any ulcer or lesions in the tongue or oral cavity.
Yes, next. No history of high risk behavior. What do you mean by high risk behavior?
So I include tell that because my patient was divorced for the past 20 years, and again, to rule out the chance of multiple sexual partners, I asked that, and I have mentioned like history of high risk behavior.
Okay. Next slide. Next slide. Please change.
The next slide is our socio-economic status of the patient.
Okay, that's all.
Yeah.
So by eliciting the history, what is your probable diagnosis? Which system is involved?
So it is a disorder of the lymphatic system, and the swelling is probably of lymphatic origin only, and probably lymph nodal swelling involving the
Why do you
cervical.
suspect a lymphatic system lymph node swellings?
Sorry, sir.
Why do you suspect a lymphatic system?
It's lymphatic system. Considering the location of the swellings, it is in the neck, just side to the neck. That is the cervical group of lymph nodes, and also in the axilla. Considering the two lesions together, they are not draining lymph nodes, so it should be two different groups of swelling together, coming together. Considering that, I've said that it's lymphatic.
Is it benign swelling of the lymphatic system or malignant swellings?
So considering the rapid growth of rapid increase in size of the swelling, both the swellings, I am erring to the side of malignancy, and also the
So
presence
short
of BC.
duration, rapid increase.
Yes, sir.
That's why you're telling that it may be due to malignancy.
Malignancy, sir. Suspecting some sort of malignancy.
What type of malignancy?
So it could be lymphoma. As it came first in the cervical region, I'm suspecting Hodgkin's lymphoma first, but it went to the non-contiguous site of axilla. It could be Hodgkin's or non-Hodgkin's.
The patient is having 6 years upon chewing also. That habit that patient is having, isn't it?
Yes,
Why
sir.
can't it be metastatic deposits in the nodes?
Yes, sir.
Why are you not thinking in that direction?
Yes, because the main reason I didn't think of that is because of the presence of an axillary swelling. So it is not draining. There is no connection between the cervical or the axillary group. So because of the swelling in the axilla, I thought of a lymphatic swelling, like involvement of the lymphatic system.
Okay.
So
Any other examiners? Sir, Rajiv Sahai, sir, Professor, sir. Okay, then go to the clinical examination.
Okay, sir. So coming to the general examination, patient has been explained about the examination procedure in detail, and verbal consent was taken. Patient examined in a well-lit room with proper exposure and adequate privacy in the presence of a female attendant. Patient is conscious, cooperative, comfortable at rest, and well oriented in time, place, and person. She is of moderate build and nourishment, weight of 46 kg, and height of 156 centimeters, a body mass index of 19 kg per meter square. The ECOG performance status score of 3. The recorded vitals were: pulse rate was 72 beats per minute, measured in the right radial artery, of regular rate and rhythm, normal volume, normal character, normal tone, no radioradial or radiofemoral delay was noted. A blood pressure of 100 over 60 millimeters of mercury in the right upper limb, measured in the right brachial artery in the sitting position. Respiratory rate of 16 breaths per minute, thoraco-abdominal type with no activation of accessory muscles of respiration, and temperature of 99 degrees Fahrenheit, and the patient was afebrile to touch. Patient has pallor, no icterus, no cyanosis, no clubbing, no edema. Generalized lymphadenopathy involving the cervical, axillary, and inguinal lymph nodes were noted, and I've examined it as examination of the neck. The inspection findings are: there is an ovoid swelling of 8 cross 7 centimeters noted in the left posterior triangle with well-defined borders. The anterior border is from the posterior border of the left sternocleidomastoid reaching up to the anterior border of left trapezius posteriorly. The medial border is noted extending 5 centimeters lateral to the mastoid process. The lateral border of the swelling is up to a 0.5 centimeter medial to the acromion process. So the lesion is involving the supraclavicular fossa. And the surface of the swelling is noted nodular, and the skin of the swelling is normal. Next. There is no, this is the image, and you can very well make out that there is a swelling including the whole of the supraclavicular fossa. There are no dilated veins or visible pulsations. Next slide. No dilated veins or visible pulsation. 3 other swellings of 1 cross 1 centimeter noted just posterior and above this swelling with smooth surface and skin over them being normal. Next. On palpation, there is no local rise in temperature, no tenderness. There is an ovoid swelling of 8 cross 7 centimeter noted in the left posterior triangle with well-defined margins, palpated anteriorly from the posterior border of the left sternocleidomastoid to posteriorly reaching the anterior border of the left trapezius, medially 5 centimeter lateral to the mastoid process and laterally 5 centimeter medial to the acromion process. The surface is nodular with variable consistency from firm to hard, and the swelling is non-pulsating. Multiple non-tender swellings which are firm in consistency and mobile in all directions noted in the left posterior triangle, with the largest of them being 2 cross 1 centimeter just above the initially described swelling. The swellings are noted to be deep to the investing layer of deep fascia. Then multiple firm non-tender lymph node swellings noted in bilateral level 2, level 3, and right level 5 lymph node stations, varying in size from subcentimetric to largest being 4 cross 3 centimeters, which was noted in the left level 2 station. These swellings are mobile in all directions and lying deep to the investing layer of deep cervical fascia. No other swelling was noted in the anterior aspect of the neck. No thyromegaly was seen. Trachea was central. Carotid pulsation palpated at the normal anatomical location. Pemberton's sign was negative. Skin over bilateral upper limb was normal. No redness, no localizing temperature. No other swelling was noted, and no ulcerations. Coming to the examination of the drainage areas, the scalp was noted to be normal, bilateral ear and nasal canal normal, oral cavity, on examination of the oral cavity, poor oral hygiene was noted with dental caries and betel nut and tobacco stains noted over the teeth. Tongue, hard palate and soft palate were normal, uvula was central, submucous fibrosis was noted over the buccal mucosa on the right side, and grade 2 tonsillar enlargement with bilateral tonsillar pillars being in the normal position, and there was congestion in the posterior pharyngeal wall. And coming to the cranial nerve examination, examination of the glossopharyngeal nerve, vagus, spinal accessory, and hypoglossal nerves were noted to be normal. No Horner syndrome noted. Coming to the examination of the breast and axilla, bilateral breasts were comparable in size, bilateral nipples at the same level. No palpable lumps were there in the breast. There was a fullness noted in the left axilla. So coming to the inspection of the axilla, an ovoid swelling of 6 cross 5 centimeter noted in the left axilla in the anterior group with smooth surface and well-defined margins. The skin of the swelling was normal, no dilated veins or visible pulsations noted. On palpation, there was no local rise in temperature, non-tender, an ovoid swelling of 6 cross 5 centimeter noted in the anterior group with nodular surface and firm rubbery consistency, and there was no fixity noted. There are multiple firm, non-tender, nodular swelling noted in the right axilla, pectoral group, largest of size 1 cross 1 centimeter, and which are all freely mobile. The chest wall was noted to be normal. No dilated veins or visible pulsations were seen. Next. Examination of other lymph node stations. Bilateral inguinal region showed similar enlarged, firm, non-tender, mobile nodular swellings, largest of size 2 cross 1 centimeter, noted 1 centimeter below the groin crease on the left side. Epitrochlear nodes were examined and found to no nodes were palpable. Popliteal nodes were not palpable. Skin over bilateral lower limbs were normal. No pigmentation, no swelling, no ulceration, no redness, and no localizing temperature. Coming to the examination of the abdomen, on inspection, the abdomen is normal with no distension. Umbilicus is central and inverted. No dilated veins, scars, visible peristalsis or visible mass. Hernial orifices noted to be normal. External genitalia normal. No renal angle fullness. Skull and spine normal. On palpation, there is no local rising temperature, no tenderness. There is a mass of 8 cross 6 centimeters noted in the epigastric region, extending to the umbilical region with all borders palpable. Superior border noted 5 centimeters below the syphisternum. Inferior border noted 2 centimeters below the umbilicus. Lateral border noted 2 centimeters from the midline on the right and 4 centimeters from the midline on the left. The surface is smooth and the consistency is firm. There is no movement with respiration. There is no intrinsic mobility, no palpable pulsation, and no transmitted pulsation. The swelling is intra-abdominal and retroperitoneal on examination. No hepatosplenomegaly. Hernial orifices were normal. No renal angle tenderness. Skull and spine normal. On percussion, there was a resonant note heard over the mass. No intra-abdominal fluid collection noted. Auscultation showed normal bowel sounds and no bruit were heard. On paravaginal examination, external genitalia normal, no ulcers or lesions noted, no discharge per vagina, mucosa was normal, fornix normal, no mass palpable, and there was no fornicial tenderness. Cervix appears slit-like and non-tender. Coming to the digital rectal examination, skin and external appearance normal. There was no skin tag, no lesions. Tone is normal. Mucosa is normal. No extra or intraluminal mass palpable. And fecal stain was present and no blood stain. Coming to the systemic examination, on CNS examination, the higher mental functions were normal. Speech, gait, and cranial nerve examination revealed normal. Motor functions of both upper and lower limb were normal. Sensory functions normal, and autonomic functions normal. Coming to the cardiovascular system, the pulse rate was 72 beats per minute. Apex beat palpable in the left fifth intercostal space itself, and both first and second heart sounds are no added sounds. Respiratory system, rate of 50 breaths per minute. Thoraco-abdominal type, air entry bilaterally equal, normal vesicular breath sounds, and no added sounds. To summarize, a 47-year-old lady with no known comorbidities presented with a continuous fever associated with night sweats and generalized lymphadenopathy with multiple non-tender, firm lymph nodes involving bilateral, cervical, axillary, retroperitoneal, and inguinal lymph nodes over a period of 1 month. The provisional diagnosis is lymphoma, and owing to the multiple groups involved, likely non-Hodgkin lymphoma. The close differential diagnoses are tuberculosis and highly unlikely but infectious mononucleosis.
Very nice presentation, Abhilash. Very nice. Very detailed examination, clinical examination you have done. You are told that the neck nodes are deeper to the deep fascia, investing layer of the deep cervical fascia. How will you clinically demonstrate?
Okay. So the largest swelling that are noted in the posterior triangle, which in which the anterior border is very close to the sternocleidomastoid. I asked the patient, made the patient turn to the same side against resistance and contracted the sternocleidomastoid, and noted that the anterior border of the swelling is getting less prominent. And with that, I made that the bigger swelling was deep to the deep cervical fascia, and the other lymph nodes that were palpable, other than the larger swelling, they were noted to are noted to have restricted mobility on extending the neck to the opposite side, and that's why I mentioned that they are deep to the deep cervical fascia.
You have told that carotid pulse is normal. Where did you palpate the carotid pulse? In the neck?
Yes, I palpated the carotid pulse against the C6 vertebra, that is at the level of thyroid cartilage, in between the thyroid, in between the midpoint between the midline and the anterior border of the sternocleidomastoid, at that level, against the Chesagnate tubercle.
In which process that Chesagnate tubercle is present?
C6 vertebra.
Transverse process
of
or
C6.
finus process? Transverse process.
Transverse process.
Okay, what's your diagnosis? Lymphoma. You
Lymphoma.
want to offer any differential diagnosis? You want to give definite diagnosis. First diagnosis is lymphoma.
Yes, sir.
Why do you say? What are the points in favor of a diagnosis of lymphoma? And particularly, you are telling that non-Hodgkin's lymphoma. First, you tell the points in favor of lymphoma, then points in favor of NHL.
Okay. So in this patient, the patient has multiple lymph node groups being involved, and there is a rapid increase in size. These both are favoring a diagnosis of lymphoma. Then she is having a continuous fever that can be taken as a remittent fever, that it is not reaching the baseline. Again, suggestive of lymphoma. And this has only been there for 3 weeks duration. So I cannot mention about the Pell-Epstein fever that is characteristic of lymphoma. The very close differential diagnosis is TB, tuberculosis. But in this patient, there is no history of tuberculosis in the past or no history of any contact with tuberculosis. She is not having any features of chest discomfort, cough, or hemoptysis. And considering all these factors and the age of the patient is 47-year-old, and it could be an age group that can be considered as a within the age group of lymphoma.
What is the bimodal presentation?
Bimodal presentation is usually seen in Hodgkin's lymphoma. Either it will be seen under the age of 20 or usually age more than 55. That is the usual presentation of lymphoma, like Hodgkin's lymphoma.
What do you mean by contiguous spread of lymph nodes?
Contiguous spreads it refers to the spread of lymph nodes from a nearby lymph nodal group. But in that case, the nodal drainage should be connected, sir. So in our case, the cervical lymph node and the axillary lymph node cannot be taken as contiguous because there is no direct drainage between these two.
What is the consistency of the lymph nodes in your case?
So in my case, the consistency is firm. Other than the largest swelling which was noted near the neck, all the other lymph nodes were noted to be firm.
Usually in Hodgkin's lymphoma, what will be the consistency of the lymph nodes?
In Hodgkin's lymphoma, we'll be seeing discrete, firm, rubbery and elastic lymph nodes.
Why can't it be a tuberculous lymph nodes?
Yes, sir. In tuberculosis, we'll most probably see matted lymph nodes. The lymph node cannot be made out to be discrete. That is because of the periodontitis phase of tuberculosis.
Why can't it be a metastatic lymph nodes?
So the consistency is firm and not hard. So and because of multiple lymph nodal groups involved, I or in the side of lymphoma more than metastatic.
Why do you say it's a NHL? Why can't it be a Hodgkin's lymphoma? Why do you say it's a non-Hodgkin's lymphoma?
So that is mainly because of the presentation of an abdominal lymph nodal group along with cervical and axillary. All these are multiple groups involved. Multiple group involvement is more commonly seen with NHL and including the abdominal lymph nodes, retroperitoneal.
Madam Ratna Chopra, madam, you please.
Reason for matting of lymph nodes?
Yes.
What is the cause of matting?
In case of tuberculosis, the stages of lymphadenitis are initial stages.
So the answer is very clear. The cause of matting is periadenitis.
Periadenitis, yes, ma'am.
So how do you differentiate a matted lymph node mass in tuberculosis from a matted lymph node mass in malignancy?
Malignancy. Just by examination.
Yeah.
The
lymph nodes will be in different stages of development. Some will be soft, some firm, some will be cystic inconsistency because of caseation, right? While in malignancy, the lymph nodes will be hard.
Hard inconsistency.
Yeah. So what are the stages of tubercular lymphadenitis?
The initial first stage is lymphadenitis. Then the second stage is periadenitis. Then the formation of cold abscess. Then cholestered abscess, and finally sinus or sinus formation.
So you were talking about extension of pathology from cervical lymph nodes into axillary. Can you describe the pathway? of extension of infection from neck into axilla?
Madam, what I told was that there is no pathway draining cervical to axilla. That is separate. Yeah, so it is non-contiguous. That is what I said.
No, they're not non-contiguous. They can be contiguous.
Okay.
Because from prevertebral space, the axillary sheath, cold abscess can track into the, from the neck into the axilla. Yeah. And similarly, from the neck, it can track into the lower limb also. Yeah. Through the prevertebral space. So supposing you were thinking in terms of tuberculosis, how would you investigate such a patient?
Madam, initially we'll evaluate the patient with the blood routine examination. We'll check for the total count and differential.
Is this extrapulmonary? Is it pulmonary?
The patient is not having any pulmonary symptoms, so it should be considered to be. It can be taken as extrapulmonary TB. Probably
can be. It is extra.
It is extrapulmonary TB.
So supposing the patient had a patient had a pulmonary Cox element as well as enlarged generalized lymphadenopathy also, what would you call it, pulmonary or extrapulmonary? So if you have a lung element attached with it, it's always labeled as
pulmonary TB.
Okay. Right?
Yes.
What is the importance of knowing whether it is pulmonary or extrapulmonary? Because you have an endpoint of treatment in pulmonary, wherein AFP are seen or not seen after treatment. While in extrapulmonary, there is no endpoint of treatment, right? And it is quasi-maxillary. You have to know the difference. Right? So in today's date, you must know the protocol of management, whole protocol of management of tuberculosis, MDR, TB, XDR also, because it's a national program now. And it's a notifiable disease, right? So any case of generalized lymphadenopathy can shift in that direction.
Okay.
Yeah, coming back to your case, did your patient have splenomegaly?
No, madam. No.
Did you mention about it? I may have missed it. Did you mention about it?
Yes, I had mentioned in the parabdominal examination. There's no splenomegaly, no hepatomegaly.
So how will you confirm your diagnosis?
To confirm my diagnosis, I will take a USG guided FNAC from the lymph nodal swelling. And
when USG guided biopsy from lymph node swelling means you'll take a prometer biopsy.
No, madam. Final aspiration cytology.
FNAC to, how will you confirm your diagnosis?
The final confirmation needs to be done with an excision biopsy and histopathological examination of the node.
So what are the precautions that you take when you do an excision biopsy?
If it could be a malignant node, so we should be careful that we don't result in the spread of the disease, including the skin.
So one is that you try to make a representative
lymph node, right? Site where the incision should be placed for following neck dissection.
Which node you will take? We are having inguinal nodes, axillary nodes, cervical nodes. Which node you are going to take for biopsy?
The cervical node, sir.
Why particularly cervical node? And from the cervical node, lot of nodes are there. Which node from the cervical you are going to take?
From the the posterior triangle node itself, which is a discrete and separate from the large nodal mass.
Central node, largest node.
Yes.
Okay, you should take. Okay, yes. Answer to the ma'am.
You should try and get a complete node, a representative node, and then the handling of the lymph node should not be much so that you do not cause crush artifacts. Right? Then how do you send the sample? And for what all investigations will you send?
Okay. We send the sample for histopathological examination and immunohistochemistry, and also we should send a sample to rule out TB with CBNAT and gene expert assay.
You'll have to take the sample in formalin as well as in saline.
Yes, ma'am.
Supposing the diagnosis comes as non-Hodgkin's lymphoma, how will you manage?
Okay. Coming to the diagnosis, this according to Anargo staging, the patient is having lymph nodal groups involving both the sides of the diaphragm. So we should evaluate further with imaging. This imaging for staging in image, the imaging suggested is PET CT. So PET CT can be taken. PET CT, if the patient is not affording, we'll go for a CT of thorax, abdomen, and pelvis separately. Neck, thorax, and abdomen and pelvis, and assess the nodal involvement as well as extranodal tissue involvement. And if the stage is advanced, like in this case, it will be 3 or 4. The patient will start the patient on a chemotherapy regimen along with the radiotherapy treatment modality. The chemotherapy regimen to be considered is R-CHOP regimen with rituximab, cyclophosphamide, hydroxydonorubicin, oncovin, and prednisone.
Any role of radiotherapy?
Yes, ma'am.
What?
Okay,
What do you understand by the mantle field?
The mantle field radiation, earlier it was given as mantle field radiation, that was the whole field was irradiated. Now it has decreased with involved field radiotherapy, in which lower doses of radiation can be given. Even 30 to 40 grays is enough to irradiate the involved field separately. So the radiation exposure to the patient is reduced. Now it is included along with chemotherapy.
What are the acute emergencies that can happen in managing patients with lymphoma?
Yes, ma'am. The patients with lymphoma, on starting the chemotherapy, the patient can go into a very important case of tumor lysis syndrome because of the extensive destruction of the tumor cells. The patient can develop tumor lysis syndrome, in which it can be identified by clinical as well as laboratory evaluation. Coming to the clinical evaluation, we'll look for the serum creatinine of the patient, which is done daily. And
yes, very good. So what the examiner is able to make out is that if you know the diagnosis, you will read the topic and come. But if we deviate from it, you will not. So you have to keep the mindset very open, right? Think of a case as a case of generalized lymphadenopathy and possible causes, and read about all possible etiologies, because you would not know in which direction your viva is going to. Right, and it can be very, very basic in the sense that people may ask you about staining techniques of the slides for tuberculosis as well as for lymphomas and the type of cells that you would come across in different types of lymphomas.
Okay.
So we have to be mentally prepared how to handle the exam.
Yes, ma'am.
In exams, yeah. Good, well done.
Thank you.
Okay, I've got a few questions. Yeah. Okay, can you tell me the basic difference between Hodgkin's and non-Hodgkin's? Just a couple of basic differences.
So the basic difference in the presentation is that Hodgkin's lymphoma. No.
Just tell me differences between Hodgkin's and non-Hodgkin's.
Hodgkin's lymphoma is the one in which there is a classical Reed-Sternberg cell present.
No. That is between classical and non-classical Hodgkin's.
Yes.
That's different. I'm talking of Hodgkin's and non-Hodgkin's. One is a systemic, one is localized. Right?
Yes.
One has B symptoms, other doesn't have B symptoms. One has got poor prognosis, other has better prognosis. Okay?
Yes, sir.
So, okay, what are Reed-Sternberg cells? What are RS cells? Where are they present?
They are giant cells which are having vacuolated cytoplasm with two large nucleus, which appears nucleus with a eosinophilic nucleoli, which appears as owl-eye appearance, which presents with an owl-eye appearance.
So it's seen in which type of Hodgkin's?
They are seen in classical Hodgkin's.
Classical type. Right.
Yes.
Classical. Okay, good. That's good.
Which type of lymphoma is common in India? Among the 4 types, nodular sclerosis, lymphocytic dominant, lymphocyte depletion, mixed variety,
Most common is nodular sclerosis type, sir.
Nodular sclerosis. If the patient is having lot of Reed-Steinberg cells, it shows good prognosis or bad prognosis?
Sir, good prognosis.
Why?
Associated with good prognosis. I don't know the reason.
Yes. What is the name of the classification for lymphoma, Hodgkin's lymphoma?
Ann Arbor staging. That's the staging.
Ann Arbor stage, isn't
Yes.
it?
Yes.
Yes.
Okay, one last question from you, Abhilash. Did this patient what was this patient's gait, and what is the importance of gait in this case?
The patient's gait was normal in this case, sir.
So, what is the importance? What does it tell you?
Considering lymphoma, like the differential diagnosis of a TB, the skull and spine.
No. It just tells you that there is no cerebellar degeneration.
Okay.
Cerebellar degeneration is associated with
CNS
Hodgkin's, and
Hodgkin's.
that can lead to ataxia, right?
Okay, sir.
What is the role of a surgeon in lymphoma?
This
Full
surgeon
of chemotherapy, you are telling. What is the role of a surgeon in lymphoma?
Taking the excision biopsy initially.
Excision biopsy. As a whole, you have to take. Okay. You should not give a bit. Full.
Yes.
Under anesthesia, which type of anesthesia you will take? Cervical lymph node. Local?
Local anesthesia only, sir. Posterior triangle lymph node, I'll do the procedure under local anesthesia.
You should never do under local anesthesia. A lot of great vessels are there, you know that. So it is better to do under GA. Okay. Yes.
Okay, Abhilash, what is Walde's ring?
Walde's ring is the it is the lymph nodal group of the neck, which is involving tubal tonsils, adenoids, palatine tonsils, and lateral pharyngeal wall lymph nodal tissue.
Tubal.
And
tubal and retropharyngeal. Okay. So they are the inner ring. And the outer ring is the? Outer ring is the?
Cervical.
That's it. Okay. Good. Very good. Excellent.
If the spleen is involved or not, how will you confirm your diagnosis by the lymphoma? Just by seeing in the ultrasonogram, is it enough? Spleen. Splenomegaly is there.
Yes, sir.
Hepatomegaly is there.
Yes, sir.
It shows that the lymphoma is there. Hepatomegaly and splenomegaly. How will you confirm whether it is?
Yes, spleno and hepatomegaly usually points to diagnosis of lymphomas.
You should take biopsy from there. Then only you can confirm your diagnosis. Okay?
Okay, sir.
Okay, right. Any other questions, sir? Sorry, sir.
No, thank you so much. Excellent. Very good. I think the class went very well.
Yes. Presented very nice.
Very
From
well.
Calicut Medical College, Kerala. Any other questions you want to ask to the examiners? To Ratna Chopra madam and Sahai sir?
I'm very thankful for this opportunity. I'm very thankful for your patient listening. Because of all the issues that happened, I'm very sorry. I don't know what happened. I was not able to share my screen.
That's fine.
No problem.
Abhilash, this is Dr. Ibrahim. So your presentation was very good. And as madam was saying, so this generalized lymphadenopathy is a very huge topic. So it is up to your capacity to take the examiner with you. So wherever you want, you have to take him or her. So, but you should also be prepared to answer other questions. So regarding the diagnosis, when you tell, it is always better to have at least 1, 2, 3 differential diagnosis. Because sticking to lymphoma and that too specifically non-Hodgkin's lymphoma, some of the examiners may not like it because lymphoma per se is a histological diagnosis, and also you are specifically telling non-Hodgkin's lymphoma. So you have to always keep it as a differential diagnosis. That is better.
Okay, sir. We'll keep that in mind. Thank you.
I think we should call it a day now.
Yes, sir.
Okay. Thank you very much, sir. I think Dr. Ganavgal is not around. I'll do the closing.
Sir, can I will, sir?
Professor Prabhakar, any suggestions for the candidate, please?
He has presented very well, sir. From Carcinoma College, very nice candidate, very nice presentation. You will get through in the first attempt itself. I wish you.
Thank you. Thank you very much, sir.
Dr. Ratna,
Yes.
Professor Ibrahim.
Congratulations, well done.
Other faculty would like to give any comments?
Keep
Yeah,
your
Dr.
mind
Ratna.
and read about these things now only as to how do you do various tests for diagnosis and.
Yes, ma'am. Surely. We'll do it.
And about the ATT also, you should know.
Slides.
Anti-tuberculosis treatment, okay?
Yeah.
What are the doses? Everything you should know, okay?
Weight-based regime.
My side, a last question to you. What is the dose of rifampicin?
150 milligrams. Sir, it is all weight-based regime, and according to different categories of the weight, the number of tablets differ. So,
No. What is the dose then of rifampicin?
For an adult?
Per kg body weight?
So 300 to 600 depending on the weight of the patient. Sir.
Per kg body weight?
Per kg, the regime is 150 milligram for 25 kgs. So, around 10.
So that's how it goes in exams, Dr. Abhilash. So you prepare flashcards for all of these and keep them with you ready through the year.
Okay.
For all drugs, it has to be in milligrams per kilogram body weight. And plus the side effects, important side effects of each drug. Okay. And plus the MDR treatment regimen and the XDR treatment regimen.
Ibrahim sir, do you have any questions to close with, sir? Sahai sir, others?
Yes, sir. Yes, sir. We have just now asked and we have said the suggestions also. It was an exhaustive presentation and we had a exhaustive discussion also with Prabhakar sir asking lot of questions to Abhilash and it was well.
He's our college senior sir also.
Yes, sir. It was a nice discussion, sir.
Abhilash, you should learn about your technique part of it also. Technique in the sense to how to connect to Zoom, this, that and all.
I had done this before. I don't know why I'm not able to connect it.
You please sort that out, because when you're presenting for a national forum, you should be having choice B, choice C also if you have a setback with something. All right. Madam and sirs, can we call the session a close, madam?
So, thank you so much, sir.
Thank you, Abhilash. Thanks to Dr. Sri Jain sir also. Faculty, Ibrahim sir, Sahai sir, madam, and others. Thanks for staying with us so late and allowing us to complete the discussion. Thank you very much. Good night, everyone.
Thank you, sir.
Good night.